Hello, everyone. Welcome to the ADAA webinar, When Kids Resist Treatment. I'm Dr. Jenny Yip, clinical psychologist and executive director of the Renewed Freedom Center for Rapid Anxiety Relief in Los Angeles, California, and clinical assistant professor of psychiatry at USC Keck School of Medicine. And I'm a member of the ADAA Public Education Committee, which has produced this series of monthly webinars. We'll be able to answer some of your questions at the end of the presentation. On the right side of your screen, you should see a Q&A panel. There's a little field at the bottom of that panel, and when you click in it, you can type in a question. Then either hit your Enter key or click the icon. You'll be listening to this through your computer speakers and do not need a telephone connection. If you've dialed in, please hang up and turn up your computer speakers. You can ask questions at any time, and we'll try to get to as many as possible. Other participants cannot see your questions. We may not have time to get to your individual questions, so we apologize if that is the case. We are recording this webinar to make it available on the ADAA website at a later date. Today, we'll be hearing from Dr. Eli Lebowitz. Dr. Lebowitz is a clinical psychologist and an assistant professor at the Yale Child Study Center, where he is part of the Program for Anxiety Disorders. Before coming to Yale, he conducted research and clinical work at Tel Aviv University and Schneider Medical Center in Israel. His research and clinical work focus on childhood anxiety disorders, with particular emphasis on family systems and the ways in which a child's anxiety impacts family dynamics and relationships. Dr. Lebowitz is the author of Treating Childhood and Adolescent Anxiety, a guide for caregivers, as well as research papers and other books in English, Hebrew, and German, and is the lead investigator on funded research on childhood anxiety. He is also the father of 3 great boys. Before we begin the presentation, I'd like to tell you about ADAA. It was started in 1979 and today is the leading nonprofit dedicated to increasing awareness and education about anxiety disorders, depression, OCD, PTSD, and related illnesses. ADAA's mission is to improve diagnosis and promote the prevention, treatment, and cure of these disorders through education, practice, and research. ADAA fights to end stigma by promoting the message that they are real, serious, and treatable. Please visit the ADAA website, that's www.adaa.org, which includes Find a Therapist, a searchable database of treatment providers, as well as free educational information and resources, self-tests, self-help groups, clinical trials, and a lot more. You can support ADAA's efforts, such as this webinar series, by making a charitable contribution on the ADAA website. Now remember, you can type a question at any time. I'm going to turn it over to Dr. Lebowitz. Welcome.
Thank you very much, Jenny. That was great, and it is a real pleasure to be able to speak with you through this really incredible initiative of ADAA, this webinar series, and I'm honored to be taking part of it. And the topic that we're going to be talking about today it really stands out as one of the undertreated and under-addressed issues in child mental health in general, and in the areas of anxiety and depression in particular. And that is the issue of helping children who don't want your help. We have some really amazing tools for working with kids with a variety of problems, from the various anxiety disorders to depression and other mood disorders, and beyond to other areas of mental health. But I think where we really struggle very often is with kids who are either politely or not that politely declining our help. And as both as therapists and as parents, this poses an incredibly tricky challenge. We can feel really, really helpless when we do have good ideas about what might be helpful for a child, but for one reason or another, that child isn't motivated to collaborate or to work in treatment. And so the topic that I'm going to be talking about is why that might be the case some of the time, and what are some strategies for overcoming those situations. So just before I get further into it, a couple of minor disclosures. We do have funding from myself and my lab have funding from the National Institute of Mental Health, as well as from the NARSAD Brain and Behavior Research Foundation, and I personally do get royalties from Wiley for the book that Jenny mentioned earlier.
Ellie, before we continue, we have some audience who said that they cannot hear you.
Oh.
Can you speak a little bit closer to the microphone?
Okay, so I'm speaking
into the phone.
Into the phone, and I will try to do a better job of staying close to the phone, and do let me know if it gets better, worse, or otherwise.
Okay, sounds good. Thank you.
All right, excellent. So one question, which seems like a really, really basic question to address, but is actually quite difficult to answer, is how many children are there actually who are refusing treatment? And the short answer to that question is we do not know. And we don't know for a variety of reasons. One thing is that most of the research that we do, in fact, the vast majority, is done on families and children who are coming to us to ask for help. Well, that right away excludes all the children who are not coming to us to ask for help. We know from general surveys in the population that the prevalence of mental health problems among children is vastly larger than the number of children who actually get help. But there are many reasons why a child might not be receiving help, everything from access to services to many other barriers or obstacles that might exist. But we know that there are a great many children who are refusing treatment. Sometimes we know it because they're actively in the room telling us that they're refusing treatment. For example, if you have worked with anxious children in the past, or if you have an anxious child, you can imagine the following scenario. Say that I'm explaining to a young girl who has separation anxiety disorder how I might be able to help her through cognitive behavioral therapy. And I might start out by telling her that in CBT, we will be working on identifying some of the thoughts that maintain her anxiety and that make her feel worried. And she might nod along with that and say, okay, I guess I could do that. Seems to make sense. And then I might say, we'll also teach you some relaxation strategies so that you can help yourself feel calmer in your body, and your mind will feel calmer as well. And she might go along with that too. But then I might also add that in CBT, a big part of treatment is learning to gradually face the situations that make you afraid. And so we'll be practicing being away from mom or being away from dad for longer and longer periods of time. And you can imagine that at this point her head has changed direction from a vertical nod to a very horizontal shake as she's saying absolutely not. I won't be doing that because you're suggesting that I do the one thing that scares me more than anything else in the world. And that's one situation where I'll know that a child is refusing treatment, and I could try to overcome that, but I might not be successful. But there's also a lot of other kids whom we don't know about. The child whose parents say, you need help, and the child says, no, I don't. And they might not even be coming in for an assessment, and we might never hear about them. A child whose parents are worried or teachers are worried, but who is not willing to even participate in an initial evaluation or assessment. And so the bottom line is that we really don't know how many children are refusing treatment, but our best estimate, based on our research at Yale and other people's research, is that probably somewhere between a quarter to a half of children who are treatment eligible are not agreeing to participate in the treatments that we have. And that is a tremendous number. We know that when we have launched projects or studies and said to parents, you come? If your child is not willing to come to treatment, why don't you come and we'll see if we can help you? We have been flooded by parents who say, yes, I don't know what to do because I can't bring my child in. And so we know that there's many children out there, but it really is hard to put a specific number. Let's talk about some of the reasons why a child might be saying no to treatment. I'll go through these quickly and then try to focus on a few of them in a little bit more detail. And just looking at this slide, one of the things that you can notice is that very often the reasons that might be preventing a child from participating in treatment are the very reasons that we might be wanting to get them into treatment, which is kind of ironic, but it's also very much the reality. So for example, anxiety can be a cause for not participating in treatment, even though it might be a very good reason to actually be in therapy. Or depression, or various developmental disorders, or parent-child conflicts, an oppositionality on the side of the child, or poor insight, or an unsuccessful therapeutic alliance between the child and the therapist, or an issue that I'll touch on a little bit more, which is family accommodation of the child's symptoms. And now I'm going to see if I'm able to transfer the slide. Okay, sorry. So let me talk about some of those in just a little bit more detail. Why would anxiety be a reason not to be in treatment? I mean, it sounds like a really good reason to be in treatment. But if you are anxious, you're probably quite fearful of new situations. You might be, as I indicated in the example that I gave earlier, you might have a fear of doing the things that are requested of you in therapy, like engaging in exposures in CBT, or talking about your frightening thoughts, or being judged by somebody new if you have social anxiety. Or you might be worried about contamination just from leaving your home and going to a new environment if you have an obsessive-compulsive disorder. Or being away from your mom in another room while you're in the therapeutic session. Or you might just be afraid of trying anything new because you have generalized anxiety and your mind is full of all the ways in which this could go wrong and might not work to your benefit. If you think about the core features of depression, you can see how they might work to keep someone out of treatment, even though that might be the very best thing to help them overcome the depression. One of the core features of being of depression is having low motivation. So you might not feel like it's worth your while to make the effort to come to therapy, to talk to somebody, to practice things. Those things can all seem really, really hard when you're feeling very depressed. And you might be very pessimistic about the outcomes. It's not going to work. It won't help me anyway, and so why bother? You might have difficulty getting up in the morning or getting out the door. You might have sleep problems that are causing you to be up at night and therefore wanting to sleep during the day and not able to go to treatment. And you might even have feelings of guilt. For example, thinking, my parents are working so hard and they don't have enough money. Am I really worth spending that extra money on for therapy? Why am I making them all these problems? I should just tell them I don't want to go to treatment, and then they'll be able, they're always saying how they don't have enough money. And when you are depressed, it's very easy to feel very guilty, even about things that rationally and realistically are not your fault. Or you might have difficulty believing that your therapist really cares about you, because your feeling might be that you're not worthy of being cared about, or that nobody really does care. The next, I'm sorry, I think I skipped the slide of depression, but it's essentially describing what I just said, the low motivation, the pessimism, the sleep problems, and the feeling that maybe nobody really cares. And another issue that can often get in the way is the issue of parent-child conflict that might be unrelated to the therapeutic issue. Children spend a lot of their childhood practicing saying no to their parents about any number of issues. I don't want to do my homework. I don't want to brush my teeth. I don't want to clear the table. There's so many things that I practice saying no to, and this can often be just one more thing. So if there's anything that's causing me to be angry at my parents, One way to retaliate might be to say, I'm not going to go to therapy. Or if I don't feel like my parents understand me, I might think that their ideas don't make sense. I don't need a therapist. You just think that because you don't get me. And therapy itself can sometimes feel like a little bit of extra work. And sometimes there is a lot that's required. I might be asked to monitor my thoughts, and that feels like homework. I might be asked to keep a log or to practice an exercise, and all these things can be exacerbated by my feeling of not wanting to do the thing that my parents are asking of me. And unfortunately, sometimes therapy can feel, agreeing to go to therapy can feel to a child, and even to a parent, hopefully not to a therapist, like surrender to the parent's will. And anytime that happens, the likelihood of a child really engaging in therapy is quite low. Another issue that can get in the way is poor insight, or a difficulty for the patient, for the child, to recognize that they actually do have a problem that requires treatment. And it's often the case that children in particular, although adults too, do not have very good insight into their problem. And so, for example, a child suffering from panic attacks might very strongly believe that there's a physical reason that their heart is racing and they're out of breath. They might believe they're having a heart attack, or that they have some other physical condition that's causing it. Or a child with obsessive compulsive disorder might find it very difficult to accept that his or her thoughts are not rational and that no bad thing will really happen. And so going to therapy in that situation can be extremely counterintuitive. If I don't think I have a problem, then why would I be going to treatment at all? And finally, I want to touch on another issue that's particularly important in the context of anxiety disorders, including obsessive compulsive disorder, which is the issue of family accommodation. It's the most natural thing in the world for young children, when they're feeling afraid or stressed or anxious, to rely on parents to help them to feel better, to help them by removing those things that make them afraid, by doing instead of them those things that are frightening to them. And it's the most natural thing in the world for a parent to want to help their child to avoid distress. After all, what parent does not want to help their child to not feel distress? And it's a healthy and normal thing to feel. However, when you have a child with an anxiety disorder, very often what will emerge is a pattern whereby the parents are making many changes to their own behavior that are all aimed at helping the child to avoid feeling anxious. And when that happens, unfortunately, the child's anxiety can often get worse, because that's exactly the opposite of what we would normally be doing in treatment. When you go to treatment for anxiety, your therapist will likely challenge you to try to regulate your own anxiety. But here, the parent is regulating it instead of the child. Your therapist is likely to challenge you to confront the things that make you afraid. But here, the parent is actively removing those things. And so to try to bring it to life, let me give a few examples of family accommodation, and hopefully you'll be able to start to see how these behaviors can actually be counterproductive to a child working in therapy. And so, for example, if you have a child who's very worried because they have generalized anxiety disorder or a similar condition, they might be bombarding parents with endless questions. Is this going to be okay? Is that going to be okay? Am I going to get sick? Are you going to have a car accident? Are you going to get divorced? Am I going to do well in school? Endless questions, and a parent might become drawn in to endless reassurance providing, by answering those questions again and again. And that's natural, but what is essentially happening is that every time the child feels anxious, that child is relying on a parent to remove that anxiety by providing the reassurance. And so they're not learning to regulate their own anxiety, but they're also not having to deal with the anxiety because the parent is removing the distress. A child who has separation anxiety, for example, might rely on a mother to sleep next to him in his bed. And very often with children's separation anxiety disorder, what we'll see is that even at quite advanced ages, they're sleeping next to their parents. Now that allows the child not to feel the anxiety that would otherwise be associated with the separation anxiety disorder, but of course it interferes with the parent's ability to go about their routine in a normal way. But a child's motivation for treatment might be significantly decreased when they feel like they have another solution which is better. Rather than my going to treatment and practicing being away from mom, she can just sleep next to me. And so the accommodation maintains the anxiety and reduces the likelihood of treatment. If I have obsessive compulsive disorder and I worry that everything is dirty and I wash my hands many times, there might come a moment when I ask my parents to wash their hands, because otherwise the dirt on their hands makes me anxious. After all, isn't it mom who's preparing dinner or dad who's preparing breakfast for me? Well, if their hands aren't clean, then of course that would make me anxious. But rather than coping with that anxiety or learning that I can be healthy even if I don't do the rituals or going to treatment to get help, I have a better solution, which is mom and dad accommodate my anxiety symptoms. And so it's not surprising that we see quite a strong connection between the level of family accommodation and the level of severity that the child and the parents are reporting. The accommodation makes it easier to avoid the difficult situations, and it lowers the motivation for treatment. It can also reduce insight, because my parents' accommodation may appear to me to be confirming my anxious beliefs. And so, for example, if I believe that I need to check that the doors are locked 3, 4, or 5 times every night before I go to sleep, well, if my parents are doing those checks with me, doesn't that give me the sense that they actually believe it as well and that my fears are correct? If I think that I'm having a heart attack when I'm actually having a panic attack and my parents take me to a hospital, doesn't that seem to confirm that I actually am having a heart attack? And so you can see how the accommodation lowers insight and is counter to the goals of treatment, and how it also is associated, as this graph can show, with increased severity of anxiety, which, when you stop to think about it, is quite ironic and a little bit tragic, because accommodation it's sort of an abstract word, but what it's actually describing is parents pouring endless amounts of energy into trying to help their child to feel better, while in actual fact what they're seeing more often is that their child is getting progressively worse. And so this can be one additional reason why motivation for treatment can be quite low. And I put this slide here, and probably most people will not be able to guess what that is a picture of, but I will tell you that it's a picture of a necklace shaped like the molecule oxytocin. And you can apparently now buy this oxytocin necklace on Amazon, because oxytocin has gotten very famous as a kind of love hormone, and it is in fact quite linked to interpersonal close relationships and behaviors, and it is also, as our research has shown, linked to levels of family accommodation and separation anxiety. And so it's possible that one of the biological underpinnings of the dynamic that I was describing before, the increased anxiety and the reliance on parents and the accommodation that the parents provide, is actually being modulated by this hormonal system of oxytocin in both the child and the parent. But knowing that, understanding these reasons why a child might not be collaborating with therapy or might be refusing treatment is not yet a solution to what to do in that situation, because we're still faced with a child whom we might understand better, but is still saying no. And so the question becomes, what should you do when a child is refusing treatment? And there are several options that might come to mind. Some might say, well, let's try anyway. Maybe we can force the child to go to treatment. Maybe we can bribe a child to go to treatment. Maybe we can drag a child into treatment. So one option might be, okay, CBT is the best treatment we have currently for childhood anxiety disorders, or it's a frontline treatment for depression in children, so perhaps we should try it anyway. Or another option might be to say, well, what about medication? If a child is not willing to do treatment, should we be using medications instead? And a recent webinar in this series addressed the issue of medication in childhood disorders, and it's certainly one option to consider. And another option that might come to mind is alternative therapies. If a child is refusing one treatment, perhaps they'd be willing to go along with other treatments. And there are therapies that are less demanding of children, things like play therapy, for example, which, although it lacks the strong evidence base that CBT has for anxiety, might be more appealing to some children. Or maybe we should do nothing at all. Perhaps we should just bide our time and hope for the best. Well, I would say that some of these options are better than others, and I'm going to try to point to a few guidelines that might be helpful in formulating a response and a plan to deal with a situation where a child is refusing treatment. And I'm also going to point to one alternative that's often overlooked, but is actually very powerful and is worth considering. So one thing to have in mind is some of the things that we do will increase a child's willingness, while other things are likely to decrease that willingness. And most parents are probably aware that one of the things that decreases, that reduces a child's willingness to collaborate with just about anything is nagging. And therefore, one piece of advice that I would give to parents is don't nag your child about treatment. It's not helpful. Every time you see the anxiety or the mood acting up, every time you see them avoiding something that you'd like them to be doing, it's not helpful to jump in at that moment with, well, you should be in treatment. Why aren't you in therapy? Nothing reduces motivation like the feeling of being nagged, and nothing convinces the child that this is something that they would be doing for their parents more than nagging. And so if you want your child to think that treatment would be something for their interest and not something they would be agreeing to do for you, nagging is probably not your best option. Another thing that I would suggest considering doing is having somebody else speak to the child instead of the parents. Very often, parents are reluctant to include other people in a discussion about their child's problem, whether because they want to protect their child from feeling embarrassed about having a problem, or whether because they feel like they have failed in some way by the fact that their child has a problem that needs help. And these are all misconceptions and fallacies because, of course, children from every kind of family and every part of the world do have issues and do need help. And very often they will be more open to listening to the advice of an uncle or a respected friend or a last year's teacher or their karate instructor than they will their parents. We're all familiar with how our children go to other people's houses and seem to behave a lot better and to be much more receptive. And I think that asking somebody else to speak to the child can often be a very useful strategy. Don't oversell treatment. Don't promise something that's not realistic. It's not 100% sure that if they go, then they will absolutely, for sure, feel better within 3 weeks. Of course that's not true. And trying to oversell like that is likely to be counterproductive as the child's trust in the treatment is reduced. Another thing that can be useful is to not make the decision about going to therapy or not going to therapy, because that's a kind of long-term decision. It's like I'm signing up for a whole year of work. I would suggest saying to a child that they should go just one time to talk with somebody. And I would recommend, and this is what I ask parents who are bringing their children to me to say, I would recommend saying in advance and very honestly that if they do not want to come back, they won't have to. And I say that because I think there's very little utility in forcing a child to go week after week, but that if you're able to get them into a therapeutic encounter with somebody who's a good clinician, then very often if they're there without the stress of having been forced to sign on to a year or months of treatment, they might actually find that they are making a connection, and they might, of their own volition, choose to come back. And finally, I would also say that we need to break the equation that suggests that if we can't get a child into treatment, then we cannot be doing anything at all. And that's simply not true. It's not the case that the only thing you could be doing to help your child is bringing them to therapy. And in that context, I want to highlight one option, which is relatively, I'd say, underutilized in the case of childhood disorders, which is parent-based treatments. Research on parent-based treatments, especially in anxiety disorders, has shown them to be as effective as child-based treatments. Now, that's sort of counterintuitive, because you would assume that if your child has a problem, well, presumably they are the ones who need to be in treatment. And that just seems to make common sense. However, it's important to remember some of what we talked about before, which is that a child's anxiety disorder is not only affecting the child. It doesn't impact only the child, but it impacts the whole family system. And so, while it's true that if your child has a dental cavity, you probably want them to be in the dentist chair, and you don't want the parent in the dentist chair. Or if the child has flat feet, you definitely want to put the arches in the child's shoes. You don't want to put them in the parent's shoes. But that is not the case for childhood anxiety. In fact, a child's anxiety disorder doesn't live inside the child the way that a dental cavity does, or the way that the child's feet go only into his shoes. A child's anxiety exists between parent and child because of that family accommodation, and because children naturally rely on their parents for help in coping with anxiety. And so parent-based treatments offer a very powerful alternative to direct individual therapy with the child. They can be just as effective, and they can be done either in addition to child work as a kind of adjunct, added component of therapy, or they can be done instead of direct work with the child. And so in the case of a child who's refusing treatment, they can offer an alternative where things might seem a little bit stuck. They don't rely necessarily on child participation, and they can teach the parents skills and provide tools that the parents can then implement at home to the child's benefit. So what are some of the goals of parent-based treatments in the context of anxiety disorders? Well, there are several approaches that have been taken for parent-based treatment of anxiety. In some cases, parents are trained as what we sometimes call lay CBT therapists. And so the parents can learn to implement with the child at home skills that the child would otherwise be learning in treatment. For example, parents can begin to point out to the child cognitive distortions, or can teach a relaxation skill. In other parent-based treatments, the emphasis is placed on general parenting skills, such as problem solving or contingency management. And sometimes parent-based approaches have tried to directly deal with parents' own anxiety that might be amplifying the child's problems. One alternative to these is to consider a treatment that is explicitly focused on reducing family accommodation, which we described earlier. And so this table summarizes some of these approaches. You can train parents as lay therapists. You could teach parenting skills, try to address parental issues, or you can directly address a parental behavior that bears on the child's problem, as is the case in family accommodation. And in the little bit of time, I'll try to give you a little bit more information on a program called the SPACE program, which directly addresses the reduction of family accommodation as a means of treating childhood anxiety disorders in cases of child treatment refusal, or in other instances, alongside direct work with the child. And so this is a program which is parent-based. It focuses on reducing accommodation, but it emphasizes a supportive parental stance toward the child. And so simply saying, don't accommodate, is often very bad advice, because A, a child might feel somewhat neglected or abandoned by parents who have until now been accommodating, and second of all, because a child might resist the changes that the parents are making. So if I have been answering my cell phone 40 to 50 times a day because my child is very anxious, if I suddenly refuse to answer the phone without providing some explanation or without setting the stage for that, my child might feel quite distressed. They might feel angry at me, and I might find it difficult to persist. And so in this program, we emphasize not only the reduction of family accommodation, but creating a supportive parental stance toward the child, one that recognizes the difficulty that the child is experiencing and that empathizes and acknowledges that difficulty, but that also expresses to the child a belief in that child's ability to tolerate a certain amount of distress. And so parents would work through a gradual and systematic, structured intervention where they first learn to understand the mechanisms surrounding the child's anxiety, what might be triggering it, but also the parental involvement, the family accommodation. They would spend time mapping out the ways in which their behavior might be facilitating the child's avoidance through accommodation, and they would choose a specific target and then formulate a plan to reduce the accommodation. And the parents would be provided with tools to deal with any difficulties that might arise during treatment. For example, if a child becomes distressed or angry at their behavior. Or, in another example, they might be provided with tools to increase two parents' ability to work together collaboratively, because very often two parents will have differing views about what is accommodation and what might be helpful or unhelpful to the child. Parents of anxious children often find themselves in disagreement, where one parent might be more accommodating or more reassuring to the child, while the other one might be a little more demanding. And those disagreements can make it difficult for two parents to work together in a successful collaborative way. And so over the course of treatment, they would be working through the reduction of accommodation in a supportive way and learning those skills. And I'll go through this part very quickly so that we leave enough time for questions. But in a clinical trial of this program, parents of specifically treatment-refusing or treatment-refractory children, meaning that that all the parents in the clinical trial, in the study, were parents of children who had either refused to participate in CBT or they had been to CBT but had not gotten better, meaning that these were children who had not benefited from direct individual treatment. And yet, over the course of treatment, through parent work alone, they were able to achieve meaningful reductions in the child's anxiety symptoms and in the family accommodation. And so this makes quite a strong argument for our ability to help children even when the child is refusing treatment directly. And so the take-home bottom line messages from this presentation are that when a child is refusing treatment, we should not give up. There are still alternative options. There's still work to be done, including options that might be geared toward increasing the child's motivation, such as agreeing to try a therapist just once with an open acknowledgement of the child's ability to decline to go further, or maybe just trying a different therapist from one that they have not formed a good therapeutic alliance with, having somebody else talk to the child so that it's not another instance of the parents badgering and nagging the child, considering parent-based treatments or alternative strategies such as medication, and keeping the issue on the family agenda so that we don't sink into a kind of helplessness where we wring our hands at the child's difficulties but are unable to take active steps to help them. And with that, I guess I will stop the front lecture part of the webinar, and I'll be happy to try to address questions.
Thank you, Dr. Lebowitz. There are some questions coming in already. So, first question I have is, my 11-year-old is bipolar with comorbid anxiety. Most days he fights taking his meds. Any suggestions?
This is a common and very difficult situation for many parents. Clearly, a child on medications, and in particular, I don't of course know the specifics of the medications, and I also would not want to use, and I should say, I guess maybe it's a good point at which to say that a forum like this is by nature limited, and I wouldn't recommend taking the thoughts in this kind of presentation as an alternative to actually following a physician's consultation and advice. And of course, I don't know the specifics of the medication in this case, but certainly for a lot of the medications that are used in mental health in general and for bipolar in particular, the ability to monitor what the child is getting and to make sure that they're getting a consistent dosage can be extremely important. Sometimes the solution is simple, and sometimes it is not. Simple solutions can include finding alternative ways to ingest the medicine. Sometimes children will put up a strong fight about medication, but what they're often fighting is not actually taking medication. It might be swallowing a pill. And so there are, in some situations, we're able to find an alternative, such as putting it into food or getting another form of the medication from a pharmacy, and that can be a kind of easy solution. In other instances, we're able to use a schedule of reinforcements and rewards in order to motivate a child to stay on the medication that they're supposed to be taking. And so whether it's sticker charts or money or, and of course I'm not suggesting large scale rewards, but sometimes small rewards can be very motivating, and you need something that's going to be sustainable over time. As a general rule, I'd say you're probably better off rewarding your child for doing something that you'd like to see them doing than you are punishing them for not doing something that you'd like to see them doing. And so children are more motivated by rewards, and I would try that as a strategy. Here also, as in the case of the psychotherapy or other treatments, I would recommend trying to have somebody who is not the parents address the issue with the child. If there is somebody that you can identify, whether it's an aunt or an uncle or a neighbor or somebody whom the child knows and trusts, you're often able to learn more than you are directly with the child. And I'd also try to figure out whether there are particular issues outside of the swallowing it that might be keeping the child from wanting to take it, such as certain side effects that might be uncomfortable for them, or just the time of day. And sometimes underlying a resistance to medication is a sense of not wanting to feel unhealthy, and a discussion about, or sometimes it feels like a reminder of the problems that it's trying to treat. And in those situations, a discussion, whether with parents or with a therapist, about the meaning of the medication and various thoughts or stigma that might be attached to it can be useful. I know that a lot of parents find themselves falling into I don't say it as a criticism, but I think that often we sort of find ourselves falling into what can be a trap, which is trying to give our children medication without the child's knowledge. And as children start to get a little older, that can often backfire quite severely, and I would not recommend that as a primary strategy.
And you've given some really great suggestions. I think what I'm hearing and what the audience is hearing is that ultimately you want to find out why the child is having a resistance to taking the medication so that you can address that why, rather than just assuming there's a blatant refusal.
Precisely. Yes, that's well said.
Okay, here's another question. What would you suggest for an adult child who suffers from anxiety attacks? And I'm assuming this is an adult child who is refusing treatment.
Yes, that is actually a very interesting question, and we are in our group actually quite focused at the moment on the issue of adult children. And by adult children, essentially what we mean is adult offspring who are typically living with their parents. And this is quite a common phenomenon. I don't want to project too much onto the person who's asking the question, but a common scenario is for someone who has emotional or psychological difficulties, even into adulthood, to be remaining at home and struggle to maintain what most people would consider an independent lifestyle, meaning they're in work or in higher education or otherwise sort of productively or gainfully employed. And this can place tremendous stress on the parents and on the young person as well. And unfortunately, it's a topic that has been treated very badly it's been treated very little by the professional field and been treated very badly by the media. And so very often you'll read about this kind of situation as characterized by a common name that you'll sometimes see because of the movie is failure to launch. And it gets a lot of kind of social criticism in the media, so that kids or the adult child is characterized as being lazy and the parents are characterized as being indulgent. And what I would suggest to people in general is that that's not the case, but that the same issues that can prevent a child from being independent because of anxiety, whether it's panic or another form of anxiety, can simply persist into adulthood. And the pattern that emerges in childhood of reliance on parents for protecting me from the world that triggers my anxiety can also persist. And so my suggestion would be similar to what I described in the childhood anxiety, would be to try to identify the ways in which parents are accommodating excessively the anxiety. And very often we'll find a lot of excessive accommodation, including everything from services in the house, like food and laundry and grocery, all the way through dealing with anything that represents the outside world, money, etc. And using those as a means, not of punishing the adult child, because I really don't think that anyone in this kind of situation is to blame, but as using them as gradual motivators toward increased independence. And so a gradual reduction in those services, which when done carefully, and I would recommend doing it in consultation with a therapist, either for the whole family or just for the parents, but a gradual reduction in that accommodation can sometimes stimulate greater independence in the child. In one study that we did with the families of 27 adult children who were living at home and highly dependent on parents because of a variety of mental health issues, from anxiety and others as well. We were able over a period of a few months to lead to really significant improvements in the independent coping. So in some cases leaving the home and living independently, in other cases beginning to work. But it has to be done very delicately and thoughtfully. You don't want to place sudden and extreme stress on an individual or a relationship.
And what it sounds like is that a lot of parents have one of the big challenges to find where that boundary is, right, between how can I resist accommodating yet not completely be disengaged from my child.
Yes.
And what you're saying is that, because you have an adult child who's still reliant on you, what then a parent's goal would be to provide motivation for the child to feel independent so that they feel the confidence to be able to go out and do things on their own without being so reliant on family members.
Right, I would agree with that. To provide motivation and also to express to the child that they see him or her as able to function more independently, if not, I think goals have to be set within reach, a little further from where we are right now, but not that far that they seem fantastical and unrealistic. And so setting goals that are just out of reach so that the motivation can actually spur to something that is productive.
Absolutely. Okay, well, we have a couple of more questions, and we only have a few minutes left. So this is a quick one. What does SPACE stand for?
Oh, that is an excellent question. It stands for Supportive Parenting for Anxious Childhood Emotions.
Okay, that fits very well into what the topic is that we're speaking of today. All right, next question. This is a little bit more complex. Okay. What happens when the parents are almost wanting for the child to depend on them, even though they say they don't like the behaviors but don't want to change to help the child become more independent? It's kind of like a catch-22, right?
Yes. So this is very interesting, and certainly it comes up a lot in anyone who is sort of trained in family therapy as a lens. But we do also, I would say, see it as a real thing in clinical work. I believe that in everyone, in the child and in the parents, there exist multiple motivations. And so the child who is saying, absolutely not, I'm fine just the way I am, I don't need any help, I will not budge 1 inch, within that child, I believe there are additional voices as well, including a voice that says, I wish my life could be a little bit better and just a little bit more like my peers whom I see doing things that I can't do. And likewise, I think that within parents there exist multiple motivations. And so there may be a voice within a parent that feels, this really works out okay for me. I am pleased to sleep next to my child every night because I feel lonely if I don't. Or I want to keep my child, a protected baby that I can cover in my cocoon of protection, and I dread the day that they'll go out and be more independent. But I believe that within that parent there are also multiple voices, including a voice that wants to see their child thrive, that wants to see the child grow, and that wants to be, even though it threatens other voices, that also wants to see the child being able to cope independently. And what I try to do as a therapist is speak to what I consider to be the healthiest voice while being respectful of the other voices as well. I wouldn't judge a parent for having a voice within them that wishes they could keep their kid a baby forever. I'm a parent and I have that voice too. But I try to keep it just one of voice without letting it decide all of my decisions. And as a therapist, I would speak to the voice that I think needs to be heard and be respectful of the other voices rather than judgmental of them.
Absolutely. And it sounds like that at the end of the day, you want parents to do what is going to be the best for the child, for their future, and for them to feel empowered as a young adult. And how do we reach that point with the parents?
Right.
Okay, well, we have one more question. This question is a little bit more complex as well. I have an 11-year-old who has separation anxiety, and she has not gone to school for 3 months, and the schools are telling me to just drop her off and leave. What do I do?
Yes. Yes. Well, this is another, I'm grateful to whoever asked the question, because it's another it's a question that's faced by many parents, and there's lots of people who are nodding their heads right now as the question emerges. School refusal is a tremendous issue, and many children are more children are declining to go to school than are declining to go to therapy, and it's certainly a big issue. And there's many causes. Separation anxiety can be a cause, social anxiety, and many other, anything that makes school more difficult can be another challenge to that. My advice for an 11-year-old who's been out of school for 3 months would be different from what the school is saying. And again, it's very, very hard to give very specific, concrete advice for a particular case without knowing more about the case. And so I'm sort of discussing it as a kind of abstract case and sharing my thoughts. But of course, in a specific consultation, I'd want to know more. However, generally speaking, I would say that my thoughts are a little bit different. I think what the school is trying to say is you can't wait until this child says, I'm ready. And with that, I agree. You can't just say, okay, we'll keep, when you're ready, let me know, because that is not going to work. And avoidance maintains avoidance, and anxiety maintains anxiety. And so if we just wait, time is likely to pass ad infinitum. And that is what I would hear in what the school is saying, and with that, I would agree. However, when a child is 11 years old and is out of school for 3 months, the option of simply dropping them off and leaving might not be a realistic option, and that's the truth. It's very hard. We don't like to admit it, and hopefully there's not too many kids listening, but but the truth of the matter is we don't have perfect tools for making children do the thing we want them to do. And so getting a child in the car can be very challenging. Just drop him off? How do I even get him there? How do I get them dressed? How do I get them out of bed? It's not a 5-year-old. Right? If the question was about a 4-year-old, you might say, you pick them up in their pajamas and drop them off. How do you do that with an 11-year-old? It's not that simple. And alongside that, I would say that a more gradual approach is probably going to be a better one. And so I would say I agree with the school about not simply waiting. There should be active doing. And that active doing could look like work with the child if the child is willing, where they might plan gradual steps, such as maybe for the first week, all she needs to do is get into the car and drive to the parking lot of the school. And maybe for the second week, she needs to get out and go to the gate of the school. If a child is willing to collaborate like that, there can be gradual steps. And I'm, as a therapist for anxiety disorders, I'm never scared to take it slow. I think that often goes faster. If a child is unwilling to work in therapy, well, I think the parents can still work independently of the child's collaboration. They can take active steps to increase the motivation to go to school. There can be steps taken to reduce the things that are appealing about staying home, considering what it is that the child is doing during the day, and things that might be incentives to stay out of school. They can bring pressure to bear by asking the help of other people. Have a group of 5 or 6 or 10 friends and neighbors and relatives drop by and say to the child, I think you're great, but and I've always really loved you, but I've heard you've not been going to school for 3 months, and I want you to know that's really concerning. That's something that has to be worked out. So I really support your parents in anything they do to try to get you back. That can be tremendously impactful for an 11-year-old who's not used to having problems dealt with in that way. there
So
can be...
using community resources and your
Mhm.
social support network to try to motivate the child and build confidence, and really ultimately shaping the child's motivation little by little is what you're saying will go a long way, rather than trying to just push the child to do something that he or
Precisely.
she isn't ready for, which oftentimes will backfire.
It will backfire very often, and oftentimes it's not a realistic statement. You know, it's easier to say to parents, just get them here, than it is to actually get them
They're
here.
not thinking logistically how will this actually
Exactly.
happen.
I'll say one
Well,
additional community resource, just really, really briefly, which has proven incredibly effective in many cases of school refusal, which is having children from the class come to the house in the morning and offer to go with the child to school. And we've done that in many cases of a child with anxiety who's refusing school. We'll put a list of kids together and just, you know, there's a little bit of logistics involved, but we'll get a kid there in the morning and they'll just be there, not to make the child go, of course, because they're just a kid, but just to go with them. And very often that works very, very well. And a little bit like with the medication, I would spend time trying to assess what are the factors that are keeping the child out of school. Is it something they don't like about school, or is it something they do like about home, or is it the separation, etc.?
You know, Ellie, thank you so much for all of your insights. There are, a few more questions that I wish I can get to, but we're kind of out of time. So thank you for attending, everyone. We didn't get to all of the questions, and we hope that this was helpful. Please let others know about this series and consider making a contribution to ADAA. Thank you. Thank you, Dr. Lebowitz.
Thank you very much. It's been a real pleasure. The Child Study Center at Yale has an active anxiety program, and you're welcome to seek help through our program as well as others that you can identify through the ADAA website, and it's been a tremendous pleasure to be with you this evening.
Thank you. Ellie, if you can just stay on for just a sec, let me log off.